Yeah. Good evening, everyone. I warmly welcome all of you for this AKSHARAM episode, which is a combined effort of Oxy Medical Education Committee and Foxy Medical Education Committee. It's a webinar series called AKSHARAM, and this is the fourth episode. On this World IVF Day, I would like to invite all of you for this interesting topic called infertility. So we have a lot of infertility patients these days, and this particular day has been programmed by the WHO for the amazing work that embryologists and the clinicians together from the past and present have accomplished in technological wise and also with the clinical wise. So it honors the contributions to the field of reproductive medicine, particularly IVF, and help countless individuals and couples and realize their goal of becoming parents. And this day, we have our eminent speaker from AIMS Delhi, Dr. Neena, who's going to talk about basics in advance. Now, I welcome our President, Oxy, Dr. Vijaya, to give the welcome address. Dr. Vijaya is a former professor and HOD of ESI, professor and HOD of ESI Medical College, KK Nagar, Chennai, former director of IOG, Madras Medical College, Chennai. Madam has varied interests and a lot of awards to her credit. Over to you, ma'am.
We go with the prayer song or
Yeah, we'll go with the prayer song.
Yes, ma'am. Now, next will be the lighting of the lamp. Next, we'll have a small invocation to Goddess Saraswati. Now, I request our Secretary Madam, Dr. Geeta Lakshmi Madam, give the vote of Oxy prayer. Geeta Lakshmi Madam is Associate Professor at Government RSRM Medical College Hospital, attached with Stanley Medical College. Madam is a UG and PG teacher and presented a lot of papers and posters in various conferences. Over to you, Geeta Lakshmi Madam, for the Oxy prayer.
Thank you, Dr. Karpagam. So, a very good evening to everybody. It gives me an immense pleasure on behalf of Oxy, as a Secretary Oxy, to welcome you all. And I extend my heartfelt thanks to Dr. Neena to participate with us for this program. And this is a very interesting topic. I welcome Dr. Kiran Madam also. And all the events go only with the blessings of the Almighty. So we'll go on with the Oxy prayer. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you so much.
Now I request our President Madam to welcome Dr. Kiran Pandey. She's the chairperson of Medical Education Committee, FOXY.
Kiran, welcome Kiran, and she's a very, very good friend of mine, very close, of course. And through her only I got interest to come into the Medical Education Committee, and she's a chairperson of Medical Education Committee, and she has done wonderful work in spreading the knowledge to all the younger generation, which is the need of the hour. And now at present, she's a professor and former HOD of Department of Obstetric Gynecology in Kanpur, and she's a professor GMC, Jalan UP, and she's a ICOG Governance Council member 2021 to 23. She's a peer reviewer of Indian Journal of Obstetric Gynecology since 2021. President Kanpur Menopause Society. Very soon their Menopause Society conference is coming in Kanpur, and President UP chapter AGOA 2024 to 26, past president of COGS and IMA. She has more than 35 years of teaching experience, and she's actively involved in OXY and lots of research activities and awards. And we are so happy to have you with us, OXY Medical Education Committee, and along with FOXY Medical Education Committee. Welcome, Kiran.
Thank you, Dr. Vijaya. That's for very kind words. I really appreciate it always. I mean, your topic and your interest into this medical education field is a very, very enormous. And you select always the very good speakers and the topics. So this is it's very good. Thanks for the opportunity to participate in this AKSHARAM 4. This is the 4th episode which we have together brought out, the OXY Medical Education Committee and OXY Medical Education Committee. At the outset, I am thankful to our President, Dr. Jaideep Tank, and Secretary General Dr. Madhuri Patel to give us their permission to conduct these programs. And it's really Dr. Secretary, Dr. Geeta Lakshmi, and you are doing wonders. And please do continue this. Our speaker, Dr. Neena Mravitra, well, who doesn't know? She's professor and at HOD AIMS, and I do know her for a very, very long time when she joined as an assistant professor. From then on, I know that that she's a very good orator, and I know her capabilities, and she has now grown up to the head of the department post. So welcome, Dr. Neena. And infertility, the topic which has been selected is a very vast topic. Though it's a very common problem, every OPD, one person will see 2-3, at least minimum 2-3 infertility patients. Still, I would say every patient is different. Every patient, though how we do have so much standardization into the basic workup, from there to the advanced investigations and advanced newer and newer technologies coming up for the salvage of these unfortunate patients, or the suffering persons, not only personally but also the socially. But still, every patient has their own individual customization. They need different tackling of the problems, and I'm sure the Neena will explain it in such great thing. These postgraduate will be benefited because they have to deal every day with this to come into the field. And of course, the time is good, and interaction is also, Dr. Vijay, I'm thankful that you are giving very good interaction time with the. That's also a very unique part of it. Whatever they want to question, their questions in their mind can be discussed by the experts. That's a very good thing. So without taking any more time, or let's not come in between the students and Dr. Neena, we'll start with the program. And I would like to be there as much as possible. And let's hear it, because how much you do infertility, how much you tackle it, how much you read it. Still, as I told before, lot more to study, understand, and tackle it. So thank you very much, Dr. Vijay, for giving me this
Yeah.
opportunity.
Thank you,
And
Kiran. Such a lovely words. And can we have the CV of Dr. Nina? Yeah. Yeah. Dr. Nina is professor and head department of OBGYN, All India Institute of Medical Sciences, New Delhi, head of the WHO Collaborative Center for Research in Human Reproduction, President-elect in Indian Fertility Society 24-26, Senior Vice President IFS 2022 to 2024, and Commonwealth Fellowship, Boyce-Cat Fellow, ICMR DHR International Fellowship for Fertility Preservation from France, Malcolm Black Sheep Award, Overseas Fund Award, Imaging Science Award, CS Dawn Award, and Korean Research Award. And she is research interest is in endometriosis and of course fertility preservation and ovarian tissue cryopreservation. Lot of funded project through ICMR, task force on GTP, PCOS and ovarian tissue cryopreservation, stem cells in atrophic endometrium, more than 135 papers in peer-reviewed journals. Nina, welcome. And every month we have this program, webinar, and every time I really break my mind to bring the best to the students, because especially from apart from South, because South they often listen to the lectures in conferences. So every month, this month is over, next month, I'll start thinking from today only. When I thought of infertility, I thought of you. So I was just praying you should accept immediately. And I know I have chosen the best person and the best teacher for the student today. Over to you, Nina.
Yeah. Good evening, everybody. I think thank you so much, Dr. Friends who are there, Dr. Vijaya, Dr. Geeta, Dr. Kiran Pandey, Dr. Sairam. I'm truly humbled when you say you choose the best, because I'm certainly not the best. That's the first thing. I have made this effort because the introduction to the subject has been very rightly given by Dr. Kiran and of course by you all. That infertility is a challenge not for the family, for the couple, but for we clinicians. And for the postgraduates, I would say that of the workload that we see in our OPDs, I think 30 to 40% of the referrals that happen in teaching hospitals in present day are infertile couples. Of course, reproductive endocrine and infertility combined also contributes to 1/3 of the postgraduate course, if we look at it, so of the gynecology. So I won't take much time, and I would just say that I will begin my lecture, and I've taken and broken this lecture into 4 parts to say that yes, it's a couple problem and they come. And so we'll talk about the workup of a female partner, moving on to the male, then talking of how do we really take them to decide whether they need IUI or IVF or ovulation induction. So I think I will start on the basic workup and we'll see how we go in time. Maybe I can be a little fast in some areas, and we have to keep definitely time for the Q&A. So I don't think I will spend time. This is the WHO and the ICMR definition, where we have accepted now that 12 months is the time when a couple who is trying for a pregnancy with unprotected sex does not have a baby. And there are all the different definitions. Initially, the NICE said 2 years, but I think now the accepted norm is a 1 year. Of the causes, I think we would know as a couple how we attribute it, but definitely 1/3 of it is the male factor. We can't say it's the female problem. It's certainly a couple problem. And the man also contributes. So the partner, male partner also contributes. So if we look at it, there are 1/3 of them are female pathologies, and another 1/3 could be jointly unexplained or problems. But putting together, coming on to the female factors is what is the intent. So whenever we're working up the female partner, the idea is to do a root cause analysis, finding the fault, and then treating her accordingly. So as we move to look, I think ovulatory dysfunctions are the one which account for 40% of the problem, followed by the tubal and the pelvic pathology. Of course, in our Indian scenario, it's tuberculosis, which is most common, at least in northern India still. And of course, unusual problems, including cervical factors and unexplained, take 10% each. So the whole concept is how do we really evaluate? Because at the end of the day, we want to give her a baby. And I think that should be a cost-effective method, because at the end, you realize there are a lot of patients who reach us, they've drained of all their money in the want of a baby. But then we have to be justifying every investigation, every workup, keeping in mind what is the age of the woman, because there will be some tests which will be needed promptly for somebody who's age 38 versus somebody who's 28.
Likewise, the background, because if she has an infertility was even long standing for somebody who is getting married at 19, I will not wait her for until she spends 10 years and becomes 29. I think we have to look at all these factors and also factor in what is her medical and social background. So this is something that I would always like, the very famous chart that comes from the University of Hull, which came to look at what would be the fecundity of or pregnancy rates in couples who are trying sex. And we find that almost the peak of pregnancy would happen towards the end of 2 years or 24 months. And after that, it starts plateauing. So therefore, I think it's good reason for us to say that if the annual fertility in couples, 100 couples who are not using contraception, when would we sort of start investigating? And therefore, the decision came from this beautiful paper work which came in the 1970s that you should start investigating couples or women when they don't conceive in beyond 12 months. And of this, a little earlier if women who are less than 35. And of course, we will shift this duration earlier when the women are of advanced age. So if we look at what are the factors that we have to factor in, of course, age is there. So if we look at women who are beyond 35, certainly we will have to investigate them earlier, as early as 6 months. And of course, now that women are following their career paths more avidly and more aggressively, with problems, I think, of most of them reaching us beyond 37, 38, I don't think we can give them time enough of 6 months, rather immediate if they're beyond 40. If they have any other symptoms which make us suspicious of the endometriosis, PCOS, or we know that there is a male factor, we don't have to wait for 1 year or 6 months. We should investigate them earlier. Now, this is just a kind of a cartoon which I want to say why we should look at or why we need to explain this cartoon to tell them the process of pregnancy, which happens in a normal procedure, but then also to tell that when we are investigating, we have to look at a normal conception which required normal semen in the man, so as to allow pregnancy happen naturally. A woman who ovulates, who is having regular periods, provided she has healthy tubes, a normal uterine cavity, and a normal peritoneal milieu. Therefore, putting all these numbers in percentages from the literature and realizing that ovulatory factors are the number one cause to investigate. So therefore, if we get a woman or a couple, I think we start talking to the woman first. We have to talk about all these symptoms, as is the sexual history, menstrual and obs and gynae problems. Is it primary or secondary? Investigate them, go into the lab. But before that, I put their general physical examination and pelvic examination. But for me, I think a pelvic examination is nothing complete without an ultrasound. So today I would say in infertile women, I think ultrasound is part of your examination. And then move on to whether we need to do their lab investigation, as in their hormone assays. Does she need imaging? And does she need endoscopy as a second line of her investigation? So some clinical, parameters that we look in and they prognosticate the outcomes are the age. The younger the age, lesser the duration of fertility, are better chances for her to have a baby. Of course, these are some things you should always keep in mind, and I won't dwell in detail. But remember, if there's somebody who has regular cycles, a 28-day cycle, I think 88 to 92% times she will be ovulatory. And therefore, something which has come in a lot of recent papers is that if they're having regular periods, you need not even go and check in for their ovulation. Also, we would check on a lot of symptoms of thyroid, because that would give us insight whether she really needs to go in for a thyroid workup. Hirsutism, very important, because this could be part of her PCOS profile. If there are symptoms of galactoria and dietary disturbances, then we need to look in for workup for prolactin. The other factors which we also factor in, especially in our setup, is genital tuberculosis, because we do get them so often in our setup coming in from low socioeconomic status, besides all the other histories which are very relevant. Again, won't take you much in detail because I should move quickly into the general examination, including the BMI, because we know there's data that obese women have difficulty in having a baby and weight loss is the way forward. Of course, we have to look in the quick general examination and physical examination of features of androgen excess besides features of insulin resistance. And therefore, I would say more than a PV examination is a baseline ultrasound. Now, this is what a baseline ultrasound actually is needed in these women, not just to know that they have a normal sized uterus, but so much of can be picked up. And I would suggest here that to do this ultrasound in the follicular phase. Why? Because in the follicular phase is when the ovaries are quiet, We just don't want to look at the ovarian outlines, but also look at the antral follicle count. And I will tell you what AFC or antral follicle count means to a lot of people who are in their early years of post-graduation, because we would not only rule out PCOS by counting the antral follicle counts, but we would also make an idea about whether these ovaries are there into the uterus. Because the first sign to pick an endometriosis would not be a chocolate cyst, but a ovary which is on accessibility difficult, one which is getting adherent to the uterus. That's the first sign, I would say, even before she gets. And of course, when I look at the uterus, I just don't look at the size, fibroids, but also for congenital anomalies, because this is the time when I can do a baseline scan. And if you have a good machine, not just a 2D, but a 3D would virtually work like a virtual hysteroscopy. Because in a 3D imaging, I can look at the 3 dimensions and not do a hysteroscopy. So I call this ultrasound for the 3D imaging as a virtual hysteroscopy. And of course, in women who have a diseased fallopian tube, not picked up now, but if you repeat the scan in the luteal phase, you could even identify hydrosalpinges. Of course, endometrium would be very basal and thin in the follicular phase, but as we move forward and call them in the luteal phase, we look at the endometrial thicknesses, patterns, and if need be, put in a Doppler to look at whether this is a receptive endometrium, because something which is going to be receptive will be something like this, a triple layered endometrium. You can see it's typical, beautiful endometrium, which is suggestive of the rising estrogens. And of course, these are some of the pictures of a bilateral hydrosalpinx, which are there in a woman with tuberculosis, again picked on an ultrasound. So typically retort-shaped tubes to a teomas and a genital tuberculosis, and a nice hydrosalpinx there sitting with an endometrium. So these are all the images from pictures that we do for baseline scans. Of course, it's very important to do a general examination, especially know their rubella status. I think when some of them who are planning their pregnancy with IVF would definitely need a vaccination for rubella, and therefore it's good to do that. Of course, we are doing a screen for hemoglobinopathies, particularly thalassemia, particularly when they are in our side of the country. So when we look, I think I'll talk about the semen analysis later. Let's look at the first 2 tests, and I put them together: tests for ovulation as well as tests for ovarian reserves. So what is the best test? I think if somebody is having a pregnancy, I think that's the best test. But these are women who are not conceiving. So in the present day, there is a whole lot of tests named from mid-luteal progesterone to endometrial biopsies to looking at all these others. But today, if I were to say of all the tests, including menstrual history and basal body temperature measurements, which we don't do, I think serum progesterone is the best test that we do. Any woman who has a level of 3 and certainly more than 5 nanograms per ml during the mid-luteal phase, which I mean is on day 21 to day 28 of a regular cycle, is indicative of ovulatory cycles. Now, what's very interesting is that even some of them, I mean, 1/3, that's what the ACOG committee opinion is, that even if they're having regular periods, they may not be ovulatory. So therefore, this test is needed to confirm ovulation. Now, if I would look at an endometrial biopsy, now, if you look at most of the guidelines, be it NICE, ASRM, or the RCOG, or any HA, they don't recommend it. But in our setup, particularly in the kind of clientele that I get, we fall back not this test for ovulation, we are using it to screen tuberculosis, because we still see 20% of women in northern India suffering from tuberculosis. And a lot of time conventional tests, no, but molecular tests, yes, may help us pick up tuberculosis. Now, I think a lot of books would say urinary LH kits, but I just want to hear that urinary LH kits have little benefit because we may still not pick up a lot of anovulation. Particularly, there is a problem here with kits, what make they are, but also we know that they're associated, they could just be helpful for when plan their timed intercourse. So we still don't rely in this test. So I just thought I would get a kind of a chart to tell how would we kind of look at these individual tests, moving from basal body temperature to cervical mucus to serum LH, and realizing that the mid-luteal phase progesterone is the one which is the simplest, reliable, and the most commonly used. Ultrasonography is again a good test where you can look at the dominant follicle, look at features of ovulation, formulation of corpus luteum and triple line, but then you have to follow these on tracking, following the woman. And it's not costly because it's involving a machine, but it's also costly for the patient. But she travels to the clinic, she travels to the sonologist, and then is off from her work. So this is something which you have to remember. Now, I just want to put the test for ovarian raise. Now, what do you mean by test for ovarian reserves? That means we are testing of how good her ovaries are to produce oocytes if she was to have, even timed intercourse, or if she was trying, simple things like ovulation induction. But very important in today's day and age when we are seeing women at beyond 35, also when we know that we want to move them forward, not just with simple treatments, but probably maybe needing them to take them for IVF. And also when we know that there are situations where we may need to screen them, because a lot of them would be picked up as, unexpected women with poor responders when we do their test. So first thing first, are we really requiring them? Are they really a screening test? But yes, we can say in today's day, they are a good test to identify women who have diminished ovarian reserve. More important when we are doing an IVF, because we need to decide their protocols in dosing, and I will tell you later on in the last part. Also help us identify women who are at risk when they undergo an IVF to respond well, poorly, or hyper, and making decisions on their choices to avoid OHSS. So if you look at it, there is no actually accepted gold standard. There's a lot of tests that are available. And these tests can be moving from the ones which are like the dynamic test to the static test. But in today's day and age, I would say that what we really rely is on her, testing. And these are some of the definite indications where we should go straight, especially when they're more than 35 years, they've unexplained, there's a family history, she's had previous ovarian surgeries, especially when she's had a chemo radiation, or if you tried simple medicines and she's not responded well. So of the tests that we are now testing besides their age is antral follicle counts and AMH. And I will say what is AMH. But before that, I would say that I would just share you that we were using FSH and estradiol, not longer preferred test, because there is a lot of variability between the two tests in between two cycles within the same individual. So we do not rely on FSH E2 anymore, but yes, there is a place of FSH, and I'll tell you where is the place. So AMH, of course, I can't say it normal anymore. It's now an accepted marker, which gives us a lot of insight into the women's ovarian reserve. And how do we use it? We use it by doing it on the basal follicular phase between day 2 to day 5. A lot of controversy whether we use the Beckman-Coulter, we use the Roche. But in today's day, I think automated levels with Roche are the best methods. So that controversy is now taken over, because earlier we're using them on kit basis. But if in your city you have automated levels, try and use that. It correlates very well with the antral follicle counts. And the best thing is, unlike FSH and estradiol, there is least cycle to cycle variability. So it is a good marker to test whether she's a poor responder or a hyper responder. Now, what are the cutoffs? Well, AMH would be immeasurable if it is below 0.16, and somebody who has an AMH lesser than 0.5 nanogram would be considered as a poor responder. Now, what's very important is AMH is used, but does FSH have a place? Yes, FSH has a place, because if you have somebody who comes with an AMH lesser than 1, do we take a decision to offer her IVF or not, or give her a prognosis? In that case, we can certainly, but when the levels are lesser than 0.5, then FSH becomes a better test in telling us whether she is a good or a poor responder, i.e. somebody has a basal FSH, which is between lesser than 10, then I would say, yes, she still stands a good chance to give me oocytes. But if her FSH levels are hovering between 12 to 15 or 12 to 30, I would say, no, this woman with the two tests combined is not as good as somebody who had an FSH low and an MH low. So therefore, somebody who has a low or a borderline FSH with a borderline AMH deserves a trial of ovarian stimulation, as against somebody who has a low AMH and a high FSH. So therefore, FSH becomes just kind of an add-on test to help us take decisions. Now, I would just put in here, how would we use AMH? Women who have an AMH lesser than 0.9 are treated as poor responders or anticipated poor responders, as against somebody who has a level between 1 to 3.5, and somebody who has more than 3.5 nanograms or above is a hyperresponder. Now, the hyperresponders are generally the ones who have PCO and PCOS-like pictures, and the ones who are lesser than 0.9 are the ones where we think we could give them some benefit, as in something like adjuvants, but I won't dwell here to tell, because I think it's a whole lecture in itself on talking on poor responders. Now, on the average responders are the ones where I think I could try them a good, if I have to do an IVF, take a decision on the dosing and the protocols based on whether they go in for agonist or antagonist, and I will tell you later when we go to the last part. But something where is very important, if they're hyper responding, I have to be very particular that I give them smaller or softer doses, and I don't take a decision of other than an antagonist protocol, and also we consider them as we see their AFC and AMH. Now, coming on to the next ovarian reserve biomarker, and again, I say we don't do it routinely, but for somebody who's more than 35, has a past history, who we feel should go for IVF, we would use these tests called antral follicle count, which is, of course, driven by technology, i.e., needs a good ultrasound machine, the technical and a personal dependent measurement, because it needs training, and a machine which has certainly got something like a 7 to 8.5 megahertz of a transvaginal probe at least. Because what we're doing is we're measuring follicles between 2 to 8 millimeters in each ovary. So what we're looking at this group of antral follicles, because these are the ones which will undergo cycle recruitment. So in this cycle, this will be the cohort which will be recruited. And if it's a natural cycle, only one will become dominant, as against a stimulated cycle where many will be. And this is a very good, this you can always go on the fertility study. This is a paper from 2006 article, which actually tells us how the guidelines are. How should you do it? What should be the, in a 2D, how should you move the probe? How should you go from the right to the left ovary? Which planes you should, and how should you go about measuring? So these are the clinical and the technical considerations of this. And this is a very good paper. And I always tell all my DM students to read this before they start moving to do the antral follicle. So this is how you define a poor or a hyper or a low responder. Somebody who has AFC more than 20 is considered as a high responder, as compared to somebody who has an AFC lesser than 5, who is expected to be a low responder. Now, just looking at the test of ovarian reserve, again, a committee opinion which comes from the AKSHARAM, the American Society of Reproductive Medicine, which has given as this thing, there's increased risk of false positive in the low risk positive, but there's insufficient evidence to recommend any ovarian reserve as a sole decision maker. That means you can't deny any woman that, look, your AMH is low, you can't try, unless until she's very low, as in 0.06, and she's got a high FSH. But I think on the basis of an AMH, we can't take a decision that she's not fit for an IVF. Now, let's move on to the second part from the assessment of ovulation utilization to ovarian reserve. How do you check her tube? Because if she's got tubal patency, then we're happy. We'll move further to stimulating her or maybe giving IUI if the male factor is normal. And the tests are very many. But then the ones which are accepted are the standards are, we begin with HSG. We could go to high FOSI, which are available, to the gold standard, which is laparoscopy and homopertubation. I won't talk on the others. So let us look at HSG, very safe. We do it in the first 10, the follicular phase, because we know that this is the best time. I won't tell you how you do it. You're basically using urographin, which is the dye which is preferred, and it is the one which is pushed in, done in the by the radiology colleagues or whatever, whosoever. But what it is, it helps to delineate the fallopian tubes. Also give an idea of the uterine lining. The uterine cavity comes, and a lot of information may come even from on the peritobial or peritoneal disease when you are doing it. It's definitely therapeutic in some, because if the couple comes, you just send them for the HSG, and the next cycle they conceive, because there's probably some kind of mucus plug which was pushed out, and then she became pregnant. Now, what's very important here, I would highlight that it has got a high false positivity, especially when they're corneal blocks. A high false positive up to 40%. So even though it has got high specificity, we have to factor in the false positivity, and therefore many times it's a corneal block. You put in an HSG, the tubes are patent. That's the reason, because it could be a mucus plug, or the patient had a spasm, a tubal spasm, because we're just doing it in a vocal or a local anesthesia. So it is a reliable indicator for tubal patency, but not of occlusion. But what's the downside is we don't get any information on the pelvic pathology, as in periovarian peritubal adhesions. So these are some of the images. You can see these are from our HSG showing a beaded tube, typical of tuberculosis. This is a normal HSG first, to show you how the tube are being filling and spilling. The first view showing you the dye going into the cavity, and then the second or the third film showing. So that's how you see them. Two tubes which are tobacco pouch or hydrosalpinges to loculated spills, and of course when there are intrauterine adhesions, you would see some beaded tubes with some fallout areas. Now let's look on to the other method, which is again lesser invasive than a gold standard laparoscopy, and this is a sonosalpingography, which is nothing but an ultrasound where you put in a saline through a catheter and then you do a TVS, a transcervical balloon catheter is put in, and you push in saline. You first see the cavity, and then you see with the 3D, you can see the you can put on the Doppler and see the fluid flowing in. So it is essentially a 3D ultrasound in which saline is pushed, and you see in these images, you can see the image one showing you a normal cavity as against a septated uterus, which is being picked up on this SSG film, and also a septate uterus, which is being seen very nicely. So you get a comprehensive view because you're seeing fluid coming into the pouch of Douglas. When you see the fluid there, you are sure that the tubes are patent. But what's the downside is you don't know which side the tube is patent. It could be coming from one tube. So therefore, it's got a detection rate, a good positive predictive value for uterine defects. But when you come for tubal patency, we cannot differentiate is the right tube patent or the left. So therefore, this is a big disadvantage. And therefore, a lot of times there is also in between the two individuals, there may be inter-observer variability. So that is the reason why we don't use it, perhaps for the reason because we can't identify which side. Now, I just want to touch on a test which is not so commonly uptaken, at least in government hospitals in India. I know private, there are a lot of people who are doing high COSI, but in our setup, we have started doing high COSI because we know that it's available with us. It's been there in most Europe and UK. The postgraduates don't even know HSG anymore. They're just doing high COSI. And what is this? It's basically increasing the effectiveness of an ultrasound-based method. Because I'll tell you, I just told you about the pelvic ultrasound. Now, the woman is coming for a baseline scan in the follicular phase. So it is like a one-stop test. It's a one-stop solution. She gets a baseline scan, she gets a antral follicle count, and at the same sitting, you're doing a high COSI. So you're evaluating her completely at one go. And this is what is the technique where you call her, you put in the catheter, you put in this dye, and then at the same time, you do you put in a contrast dye, and you've done a 3D imaging. So what you've done is you've done her antral follicle, you've done the tubal pathology, you've done the uterine. So it's just one-stop solution for diagnosing the three pathologies: her reserves, her tubes, and her uterine lining. So 3 in a go. And many times from this, you can even pick at the pelvic pathologies also. So these are the thing. Actually, it's the contrasts are basically microbubbles which act as eco enhancers. The thing is they've got very short lifespan, and therefore you need to do it immediately. So I won't take you to the EcoVis, which was the first one available, but today we're using XM foam. This is the US FDA approved, and this is the one which is available as a tender in our hospital. We use it. We started as a part of a quality initiative thesis, and now we realize it's doing good. And therefore, we are not doing it routinely. We're still doing HSD because we've got a big, footfall of 500 patients in our OPD, out of which 140 patients are infertility. We can't offer it to all, but we are selectively doing high COSI now. Now, coming on to the test of high COSI. So as I said, it's a simultaneous documentation of so many things of the FC as well as a 3D, 4D imaging of the ultrasound. So it's a one-stop solution, and I would not take you through these figures or diagnostic accuracies, which are all there from literature on the specificity. But what's very big advantage is A, on the dye, which is very safe, B, the pain, and you are doing a comprehensive test in one go. So these are all the things which make it superior. But one thing is there that it is operator dependent. And again, the dye is costly. If you compare the cost of the dye is 20 times the cost of an HSD dye. Now, I just thought I'll get you. This is not what is available in India. This is something like way beyond us is high FOSI. I think most European countries like France, Germany, they're using, instead of high COSI, they're using another level of the hydroxyethyl cellulose and glycerol foams. The accuracy is same as high COSI. There's no difference, but it's like if I have the Mercedes or I've got money to spend and buy a Bentley, why don't I? That's the only thing. But certainly these tests are there. This is the other one which is there, the hydrosalpingo, lidocaine foam salpingo, graphy pulse. I just want to complete this, that these are there for postgraduates. I have not used any of them. I just have experience of only hypoxia. Now let's look at the gold standard. The gold standard is definitely tubal pathology plus pelvic is. But there'll be some women whom I won't do an HSG. I'll take a straight for a laparoscopy. Like I've seen, I've done a baseline scan. I see there's a chocolate cyst sitting. I see there's a hydrosalpinx. I see that ovaries are red, and so I've already got a hint that there could be endometriosis. There could be, features of tuberculosis. And then in that case, I would rather not spend time in doing a tubal evaluation, but nothing but a laparoscopy. And the intent is not to do a diagnostic, but to do a corrective or a fertility sparing or a fertility enhancing surgery. Maybe do salpingectomy if they're bad hydrosalpinges, maybe relieve her adhesions or even treat her endometriosis. So I think laparoscopy from a diagnostic realms has moved to a therapeutic realms in the workup of a female infertility. So that's what will be in some of the images to show you how hydrosalpinge would behave. And this is somebody who's already had a scan with us, and we just want to do a treatment of doing a salpingectomy to somebody who has beaded tubes and even periovarian adhesions. So this is the way the AKSHARAM says. It is not recommended as a routine test for tubal assessment because you could do with other tests. It's specific if you have a diagnosis, and it's to do therapy rather than and of course, even the RCOG say that the standard for tubal occlusion is when you have high COSI and there are no comorbidities. Yes, you should do high COSI, but if there are comorbidities, as in the patient who has a disease, then you should do a laparoscopy. So again, I will not take you. These are all things which I think I can share these slides rather than wasting time. Now, coming on to assessing the uterine cavity, you can do the uterine cavity assessment, as I said, on an HSG also, because uterine factors would contribute to 10-50% HSG, or the gold standard. The other side is when you do a hysteroscopy, you have pathology on a 3D imaging or a saline sonography or on a high COSI, then is when you do, again, not a diagnostic, but a therapeutic hysteroscopy, as in you've seen a pathology like polyp, you've seen a septum. My take is to treat her of that problem, be it adhesion, be it septum or a fibroid. So these are some of the images. I think these are from very old pictures of ours. I kept it for like a museum, like when the postgraduates undertake exam, we've retained these. And this is what a sonosalpingography or sonohistography is. You place a balloon inside and then you place a catheter and you push in the dye. And this is what is our image we created of a polyp with a saline being instilled. And this is how it looks like when you put in a Foley's catheter with the kind of a fundal fibroid there. Now, these are some of the pictures. I want to show you how it would look, some of the images. And this is when we knew that we diagnosed her with multiple fibroids. We are kind of just doing a therapeutic hysteroscopy, as in resection of these fibroids, submucosal. So basically, it is not just for evaluation, but for treating the problem. Now, again, on these sensitivities, I would say hysteroscopy is still the gold standard. And we do not routinely, but when we are doing a laparoscopy, we always combine it with the hysteroscopy. So let's look at evaluating the peritoneal milieu. When do we need it? When we have a suspicion of endometriosis. Or we know, yeah, she's got tuberculosis. I need to put in a scope to check in a perihepatic adhesions. I need to start her ATT. She's FGTB positive on molecular tests. I want to reconfirm them before I start and giving her ATT. And that's not some of the images of perihepatic, peritubal adhesions and endometriosis. That's how we would treat. And therefore, at the same time, we would also need to go in for a therapy at the same time or doing adhesiolysis. Now, for the cervical function, I don't think we're routinely doing it. We can just do we were doing many years back postcoital test or anti-sperm buddies, but in the present day in evidence, look at 2004 only NICE guidelines say that they are not recommended in the basic infertility evaluation because postcoital test does not indicate the presence or indicator of pregnancy. So it's not routinely done. I just want to add in on the hormone assays. Do we do thyroid evaluation? Do we do evaluation of the prolactin? Is it needed? I think that we in India should do it because this is coming from the AKSHARAM, where they said that we do it if there is a woman attempting, because we want to make sure that she is in a pre-pregnancy state with a thyroid which is anything between 2.5 to 4. So if it is more than 4, yes, we need to treat. But then look, this is a grade 4 evidence, because we know that if she's entering pregnancy with high levels, the cutoffs change. So the whole idea is to make a peri-pregnancy or pre-pregnancy thyroid optimization. Now, this is kind of an algorithm which I thought I could share with you people. It's again there to tell that, women who are euthyroid, we just don't, there's a big question mark, but who are hypothyroid, we keep this at levels of lesser than 2.5, because we want to make, but actually, do we really need to do the thyroid status is controversial, so guidelines vary, but in India, because we know hypothyroidism subclinical is so common, we'd rather prefer it. Now, going on to prolactin levels, hypoprolactinemia is a common problem, and we still want to check it. But again, those who have menstrual irregularities would be, but on routine testing, I think it's not recommended. So putting on to the AKSHARAM guidelines, would just say what is the basic infertility evaluation, history, physical exam, pre-pregnancy evaluation. Of course, additional tests would be, as I mentioned, and only some groups should check for reserves, ovarian dysfunctions, as in progesterone for all, tubal testing with HSG or HyCoSy, and of course, testing for uterine factor. So this is the way we would do in our workup. And I think I would just conclude: review her history, review examination, do her baseline test for her ovulation, patency, and hormone assays are not recommended. Ovarian reserve tests are not recommended, and only be recommended if there is a indication, as in I know that I have to see her age, her prior history, or I know that she's a couple where there is a male factor severe enough that she needs IVF. So that's the kind of woman I would go straight. So I would then go on, if you allow me to, if there are any questions now, or should we take the questions in the end? And I can go on to the, the next.
Go to the next thing. There are few questions are there. Then we'll note it down and tell you in the last.
Okay. So I would go on to attach my other file, which is on the male infertility.
Please post the questions in the chat box. Whoever wants to ask any doubts, at the end of the session, we can clear it.
So I need to attach my, now I'm stuck up somewhere. Facing a bit of challenge there. Yeah.
Sakiti?
No, wait. I will want to attach my. Yeah. So I will change my slide and I will go to the next slide, and this is on the male, right? Can I come to the, I think this is the work of the female. No, I think IVF. Yeah. Can you see my slide now? Is it visible?
It's visible.
Yeah, sure. So let's move from the let's go on to the male factor, because I think the husbands or the partners contribute to, couples contribute to 40% of the unknown, but if you put it overall, it's 30 to 40%. The contribution, and solely if it's isolated men, it's around 20 to 30%. So whom to evaluate? Yes, when it's a couple, you have to, it's not just the female, but it's the male, and therefore we have to look at what is the best way. I think again, history, examination, and the semen. So I would go quick, because I think we know that these are the causes. I think I can skip the causes. They're all from the books, nothing new I'm telling. But remember, there's going to be a hypothalamic pituitary disorder, which would be congenital acquired, a gonadal disorder, which causes a primary disorder of the gonads, like we know these are the conditions. Obstructive, yes, because these are the ones which could be because of the congenital absence of the vas. It could be some infection, tuberculosis, still very common. The ejaculatory duct dysfunctions, which could be even autonomic, but very important, I think, idiopathic. That means there is nothing in the history, nothing there. Even the semen parameters are borderline. I think idiopathic is a big challenge for us. Now, are the slides not moving? Somebody wrote slides not
No,
moving.
it's not moving. It's not moving.
Okay. Somebody said stop share. I think they're moving from screen is showing ART.
ART indications like that. IVF
Okay.
for
I
whom?
think I'll go again. In my thing it's
Management. What is this?
yeah. Can you see this now? It is male
Yeah,
factor.
yeah. Workup in male. Yeah, we can
Okay.
see.
Can you see this now?
Yeah.
Okay. So I think this is because I opened all the 4 simultaneously.
Okay.
So therefore, this is something which I thought is idiopathic is the most common. So again, the workup is basically involving the history, examination, and I know with women and we shy out, we send them, but semen analysis is the cornerstone. We just need all these genetic testing, imaging, and hormone only in some. So again, on the history, again, I would not spend much time because it's very important. All these histories have to be at the back of your hand, just as your reflex, talking about right from testicular trauma to medical disorders. Of course, their family history is what's very important. I'm very, very particular because when you see these young men who are going to the gym, freak, as they are gym freaks, they are pushing in a lot of these supplements. And we don't realize that the so-called protein supplements that they're taking are containing some bit of anabolic steroid. I think I make it a point, even if I don't know what's the constitution, when they come for IVF, I tell them, look, 3 months, please get off all the supplements that you're taking. Whatever, they may be good shakes, good whatever, please be off. We don't know what's affecting what. Because at the end of the day, we can't pick up the extent of DNA damage or the harm they do, even though the sperms look normal. When we're doing IVF, we're very particular in I'm very particular about asking history of smoking because more than alcohol, it's smoking, which is a disaster to the sperms. Lactose uses, yes, we can't avoid. But one thing which is very important for me is the history of diabetes. A lot of times I picked up diabetes while looking at their semen parameters. When I see that their semen parameters are abnormal, the man is young and fit, we just ask. And I think that is what I've realized, that diabetes and abnormal semen parameters are definitely linked because a lot of motility issues and morphology issues, particularly motility, is the one which gets altered when they are diabetic, or not borderline, but they're well um, uh, known diabetics. So whether caffeine intake does not affect, yes, there's not enough evidence with cell phone usages, but those cell phones are blamed, we are not very sure. Now, the general physical examination is very important. We look at their, BMIs. The obesity is again a factor. Look for gynecomastia, virilization, because that's something which tells me it could be, a patient who needs testosterone therapy. The habitus is very important. Of course, these are some things we all should know. And I think for us, very important is a complete examination, which I think all of us shy from doing when we see. And it's an honest confession. Even I shy till date. But if you were to do a complete evaluation, this is how your protocol should be, from going from the hypospadias, epispadias, looking at penile discharge to scrotum. And I think every clinic should have these oxidometers. This is something where you look at and an average volume, anything between 15 to 20, or I think between 10 to 20 is something which we are expecting. And this is the way the oxidometer helps you when you're palpating the testicles. If you're not used to actually measuring them, this is the best way to have it in your clinic and guide you. So what is the cornerstone to evaluate a male partner is a semen analysis. And I will say that semen analysis is something which is basic. You need specialized tests only in some, but then the WHO manual says you have to, and therefore I will touch them briefly. So the newer WHO 2020, which was being launched in 2021 because of the COVID got delayed, it's at least 2 semen parameter analysis done 1 month apart. Abstinence, yes, the longer the abstinence, you may not get good results. Therefore, keep to 2 to 3 days of abstinence, because if you have shorter and longer, they have both the problems. The longer the abstinence, you'll get more dead immotile sperms. But if it's shorter, you may get a lesser volume and the density of the sperms will be less. Very important that you should start the process within an hour of collection, because we first look at what are the parameters. We would look at, this is the WHO manual. I'm sure it's very easily accessible. You can download it, where they represented all the 5 continents other than India. And the WHO 6th edition is the one which has given the centiles. These are, again, not much change from the 2020, except the change came. We look at no difference at all, except that the change came little only in the progressive motility. So marginal from 40 to 42, from 32 to 30. Otherwise, all the things remain the same. So even the designation of the centiles has been the same. And this is what we say that where is the place of abnormal semen, the chance of infertility increases with increasing number. I.e., if somebody is an isolated oligospermia versus if somebody has oligoacidotetrato, the more the problems, the more will be the fecundity will be lowered. That's something which we've known. So again, on the semen analysis, you have to look at the macroscopic, which is again the coagulation, the liquefaction, the viscosity. All these have got a meaning, because if there is a coagulum, then there's problem, because there should be no coagulation. And if there's no coagulation, it indicates the absence of semen and vesicles. The semen should liquefy in less than 30 minutes, but if it's not, then you think of all these problems, right, from prostatitis to seminitis. And at times we have to add, something to we add some enzyme to liquefy when there are problems. Viscosity is very important. Of course, pH is there. We know that the pH has to be between 6, but what is important is the overall macroscopic look has to include all these. Now, volume is important because you could have a low volume. And again, a low volume, the first thing is what has been the post, ejaculation volume, because it could hint right from a CBVAD to, retrograde ejaculation to even androgen insufficiency. You have to keep asking all this to yourself. And when the lab gives you, to high volume actually means a very aggressive inflammation of the accessory glands, as in the ejaculatory ducts. So these are some of the limits that have been given. Anything which is less than 5 million is severe oligospermia. And what is AZU? That means you have taken a semen pellet, centrifuged it. On that pellet, you don't get any sperms. That is AZU. And you have to diagnose azoospermia on at least 2 samples. The gap being definitely 2 to 6 weeks apart. That is what is diagnosis of. Now, on the motility, again, I would say we have to, the lab has to look at, it's the A and B, which is very important for us. We do give the C and D, but for us, it's the A and B, and the total motility has to be at more than 42%, but the progressive more than 30% is a happy sign. Of course, isolated asteno is rare, but an isolated could basically mean either a partial obstruction or infection of the genital tracts. Now, very important, I think we put a lot of stress, and I think morphology comes very handy, as morphology will come from somebody who's very good, who's specialized to look at it. That's why when I look at semen parameters coming from all labs, I would want them to come from a lab. Like in our setup, we have isolated and dedicated lab from andrology, where we accept it from our colleagues in reproductive biology, because the technicians are so thorough on the morphology that they will give us the right diagnosis. And many times they even overdiagnose, but that's very helpful to us. This is the look. We look at both the head defects to the mid-piece defect to the neck. All these defects are looked and classified. And then any figure by the Kruger's criteria we follow, which is less than 4%, we mean that this is the strict criteria we follow. However, this is again variable between clinics. Somebody follows the Kruger's, somebody follows the guidelines. We in our lab follow the WHO Kruger's criteria, which is accepted. And if there is a morphology lesser than 4, we get vigilant, and we would rather offer them and revise earlier, as in offer them an IVF or ICSI. So the extended form examination could be looking at the biochemistry of the semen, as in fructose, or looking at, antibodies or DNA fragmentation. These are something which are not in my lectures realm, but I would quickly tell that these are the tests we'd only do in some cases, and which would mean, somebody who has, where we know that there's a recurrent pregnancy losses, there's somebody who has a recurrent implantation failure, then I would like to do a DNA fragmentation. I wouldn't really offer. Do I do tests of anti-sperm antibodies? Not routinely now, because I know that these tests have got little meaning, particularly when we are doing IUI. We don't offer in my setup SCSA or chromosome test, because they are time consuming and they don't really alter my management outcomes. Now, coming on very importantly, do we really do endocrine evaluation? Yes, we do endocrine evaluation, especially when I get a case of azoospermia. I do an FSH because I want to know whether it's obstructive or unobstructive, especially when I have some semen parameters, like I have a borderline notes where I have a semen which is showing between 5 to 10 million, and there is something in the history, like there is a decreased libido. A decreased libido could be a pointer of hyperprolactinemia. There could be impotence. That's where I want to look at testosterone levels. There could be sexual dysfunction, and that's the man where I would. So in that context, I would do it. I would do a testosterone LH, FSH and LH if I look at the habitus, but testosterone definitely if there is features of an impotence. So then you do these tests, but routinely we would not do these tests. And the endocrine evaluation is important that if I get these normal pictures of a normal test, which we're not routinely doing, is normal spermatogenesis. But then it's something which could hint as a normal test could mean that there is probably an obstructive pathology. It means the upper compartments, right from the hypothalamo pituitary testicular axis is all intact. But yes, if the LH-FSH are low, then it could be a pre-testicular problem. That means it is an HH, hypo. And this man could be benefited by giving gonadotropins, as in we give them FSH-LH combined, like in we give them HMG preparations to somebody who has post-testicular, where both FSH and LH are high. And that's the time where we get couples with abnormal, or the man coming with abnormal spermatogenesis, as severe oats, or even azoospermia, and the FSH, LH are high. So again, I won't really spend time here, but just to tell you that there are some tests which we routinely do when we have, an obstructive azoospermia, especially when you have an examination absence VAS, then I think it's mandatory to look in for the CFTR genes, because you could do an evaluation and this chromosome malabsorption is normal. Yes, in our setup, when we have severe OATs, we do microdeletions, particularly when the counts are less than 1 million. Less than 5, I won't, because again, these tests are costly. Because why? Because if I have counts lesser than 1, or I can pick whether it is which kind of a microdeletion is it, because certain microdeletions like the AZFC is more prognostically better than the AZFB. And also when you're doing testicular sperm extractions, then we know that we will never get sperms from we will not get sperm from the C. So they are poor prognosis patients. So in obstructive azoospermia, we definitely need. Now, I just want to tell, we get very bogged down when it's azoospermia. Do you think we can't help? No, we can, because the obstructive azoospermia have a very good outcome, because we can do a surgical sperm retrieval, be a PSA, TSA, or a TESE, and then retrieve the sperms. And therefore, here is a place of doing a triage by doing an FSH test. So if you do a semen analysis, you look at the physical examination and you do the FSH. If it's a normal volume semen, but there is a small testes and the FSH is raised, I'm looking at a non-obstructive. The prognosis is not good here. Getting sperms from this man would be difficult, as against somebody who has a normal testicular volume, FSH levels are lesser than 8. I think I'm looking at obstructive. Prognosis is good here. So surgical sperm retrieval will definitely be an answer. So in the evaluation, the testicular size and FSH is a very good indicator, prognosticator, and that's when we would refer them to our andrology colleagues to help us. So again, I will not take you. This is a long algorithm which basically means that the semen volume and pH. The semen volume is low, pH is low, and then I would do it as a post-ejaculatory urine sample, because my low volume could only mean that is it a retrograde or not. So if the post-ejaculatory urine is tested, there is significant sperms, it could mean retrograde. If it's not, then I think I have to look at other causes, which could be either an absent VOS or an absent VOS would mean basically going in for the testing of the fructose also. But if there is palpable VOS, I would rather go for a transrectal ultrasound and look at these ejaculatory duct abnormalities. In contrast to somebody who has a normal semen volume, normal pH, and who's got normal testicular volume, I would then go in for look at a correctable cause as an obstruction and then offer them. So for me, a normal testes volume, a normal FSH is a good prognosis as compared to the other side. Now, I won't take you, this is a little busy thing. I would rather keep it for my DM students who would actually benefit from that slide, because non-obstructive is a little more challenging, because we are going to get them as with the raised FSH. That's when we know that they're abnormal genetic test and we look in for other pathologies. But if they are normal FSHs, then there's obstructive, the prognosis definitely stands better. So again, in an azo workup, of course, history is important, but when we look at the options, when they're obstructive azoospermia, we have to identify what is the way which we're going to retrieve the sperm. Because the decision to go in for a TESE or a PESE results on our identification or the level. Again, in the realms of IVF and andrology, depending, we would go with PISA and TESE, but only certain group of non-obstructive and certain intratesticular obstruction would you go to TESE, or in present day I would say micro TESE, and I will tell you later when I do this in the IVF, slides. So again, I just want to touch a little bit of male hypo, where you know that there will be classical symptoms of testosterone deficiency. They'll have decreased testosterone production, and therefore impaired testosterone would lead to decrease or impaired sperm production. And this is the group of man who actually be benefited. I'm not going to tell you again on the causes which could go from primary causes to secondary hypogonadism because of the head injuries or the others. But essentially, you have to know this bit, because you would have to be able to help the man, where you would know what is the cause, and then help them in giving therapy. And here is the one where we believe in doing their FSH levels and also treating them with the depending on the testosterone levels. So when we go in for secondary causes, we realize that we can help them by a lot of problems like obesity, where weight loss can help, helping them, have treat that as the first line options. But for secondary, again, we would see at what age they come, especially when they are coming in the pre-adolescent. Could we give them something for the penile growth like testosterone? Adults, again, testosterone help for their growth in their secondary sexual characters and growth spurt. But in the adults, I think something which is very important when they come for infertility, I think at that point in time, testosterone is not going to help. It may rather be contraindicated, may not be good. And that's a time where we give them, gonadotrophins in the form of HCG alone if the testicular volume are normal. But if the testicular volume are low, again, the prognosis is not very good. We have to give them a combination of FSH and the LH coming from the HCG. So this is what the guidelines say. And again, a lot of us work in colleague and with our endocrine colleagues, where we get these as referrals. And then once they improve in their testicular volumes, would we do a surgical sperm retrieval and an IVF. So very simply to put that, testosterone is contraindicated in eugonadal men, because many times that taking testosterone could be a cause of abnormal semen parameters. Testosterone good if it's a HH symptoms, they are having an infantile penis, or they have that's a treatment. Now coming on to testosterone, I don't think in the present day you should consider testosterone, because testosterone could be harmful. We only give in a small group of patients where you're giving milder forms of ED to improve some depressive symptoms, or just in cases where they have insulin. Otherwise, testosterone therapy is not the answer for male infertility. I just thought I would quickly touch about oats, because oats is something which is not isolated oligo. It's generally a combination of oligoacidogenitol. It could be milder or severe version. If they are severe, obviously we will take them for IVF. But men with oats, there is data to show that they are more prone to develop testicular cancers. So the therapy is, medical therapy is definitely offered, but I won't offer somebody medical therapy if there is severe oats. Only to the ones which have got a milder version. There have been a lot of hue and cry to give them clomiphene, to give them, some bit of SERMs. The thing is that, remember, androgen is absolutely contraindicated. Do not recommend them antioxidants, because people will be taking, do they help? The jury is very, very controversial. Yes, recombinant FSH treatment has been shown in some trials to improve pregnancy when they do IVF, not otherwise. So you have to really tailor make a decision. And severe oats, go straight for an IVF and ERT. That's the answer. Medical therapy would be only in mild cases. I thought I could touch surgical sperm retrieval here or with IVF, but remember what we were doing earlier was MISA, not very popular now. Now we go and do a percutaneous, just a needle, putting in a needle in the epididymis, because microsperm extraction from the surgical sperm epididymis is no longer practiced. Only some units or old timers would say, again, individual variation surgeons. But then PISA is what we do routinely. It's very easy, simple, putting in a butterfly into the epididymis. It's without, a GA. And then TESA and TESE, today's day and age in obstructive AZU, especially even in non-obstructive, we would do a micro dissection or a micro TESE. So this is how we do it. MESA would be possible with a sedation or an anesthesia. We definitely need some block. We're putting in a kind of, under vision. Whereas in a piece as an office procedure, put in a needle or a butterfly. TESA again needs a block because it's painful as compared to TESE, where you need a small incision in the testes. And through this incision, you extract the testes, and you need expertise where you can pick out the microtubules. And then your embryologist simultaneously, in all these cases, your embryologist is there, tells you whether the sperms are retrieved, and then you move further and take them for ICSI or whatever procedure or storage. So I will just end here, and then I would go on to the third part of my talk, and which is it all good for this thing? Can I sort of go further?
Yeah, please, please.
Yes, yes.
Okay. So I would go on to the third part and think we can just end this lecture. And I would share my screen on ovulation induction. Am I getting too boring? Please stop me if you feel. Is this slide being shown? Can you see the slide now?
No, you go ahead. It's a complete discussion on infertility. We have told.
Sorry?
It's a complete discussion.
Okay, so can I go on the ovulation induction bit?
Yes, yes, yes.
Okay, so I just thought so as I said that, this is how we would look at, infertility by definitions, but we know that on the female factors, if we look at ovulatory, anovulation is a very big chunk. It is a very big group, around 35 to 40 have anovulatory. And I think the prototype of anovulatory for us is PCOS. I just thought for postgraduates here, we have a WHO classification and now a FIGO classification. I'm sure you all know it. The WHO classified into 4 varieties, from the HH to the normogonadotrophic to the hyper to a group 4 of hyper to the newer FIGO. It's not longer newer, at least three years now. The type 1, type 2, type 3, which are actually the hypothalamo-pituitary ovarian, and now they added PCOS as a separate. So you realize that the prototype PCOS is so much predominant for the ovulatory or anovulatory problems that the FIGO put it as a separate group, unlike the earlier WHO, which puts in the normogonadotrophic group. So I just want to tell here that, there is a difference to understand what is the type of therapy a woman would get if she's hypo, this means type 1 category, versus the one who's type 2 or a type 4 in the FIGO. So a substitution is something where she is devoid of the FSH-LH. That means she's hypo, so she needs substitution. And I will tell you in the protocol how do we do that. And that is the hypo types. In contrast to somebody who is anovulatory, that is a PCOS, where we need to induce her ovulation. She's not ovulating. I need to induce her ovulation. That's ovulation induction. Two, what you do is COH. That means controlled ovarian, or we simply now say ovarian stimulation, OS, where we want her to produce not one, that means she's ovulating, but I want to produce her one or more, maybe 1 or 2 if I want to do IUI, or maybe 6 to 15 if I want to do IVF. So in the realms of ovulation induction, I think I would really say, are we doing ovulation induction and ovulatory infertility? So therefore, essentially you have to understand the indications. Whether I'm doing it in a super ovulation, I'm doing an IUI where I just want maybe not 1, maybe 2 or 3, like it's a male factor and I want to do an IUI for them. I know she's mild endometriosis, so she's unexplained, and I'm doing IUI as the management, as against ovarian stimulation IVF, which would depend on whether I want to do a stimulation in a normal responder, poor responder, or cancer patient. We do even stimulate ovaries for cancer responders. And my talk in this part would be mainly because I would talk on the IVF in the next part, and therefore I would just, in this bit I would just restrict myself to ovulation induction and superovulation. That means I'm wanting a monofollicular in a woman who's PCOS, not ovulating, to maybe somebody who gets just 2 to 3 superovulatory. Now, what makes me take a decision on what I'm giving? Actually, for me, it is the cost. Because the woman who comes to me, I should give her a cost-effective treatment, something which is pocket-friendly. I can't start on high-end Bonal F or a recombinant deficit just because I work in AIMS. No. I look at the safety because I know that safety is paramount. I can't let her have a complication like multiple pregnancy or OHSS at the cost of giving her a baby. And for me, it's very important, and I put this in the cost. Monitoring is not part of your problem, but monitoring is a part of the cost because it adds to the travel of the patient. So I want to give her a protocol which is least, on the pocket in terms of even monitoring, and of course, which is evidence-based. So the first line is obviously oral, the next line will be gonadotrophins, and then of course, I put even combinations before gonadotrophins. Before pure gonadotrophins, I would rather put oral as first, combination as second, and gonadotrophins as third. So let's look at the oral. The orals are the SERMs, and I would quickly talk on clomiphene, which we've sort of started using it for more than 45 years, has still maintained its position, but letrozole has moved now as a first line for PCOS. And I won't really talk much on the sensitizers, except that I would talk a bit on the metformin and the minoxidil. So clomiphene, of course, you all know it is the first choice in PCOS in the group 2 and still is the first choice. But now the first place is being shared by letrozole as well. I don't want to talk on the physiology, but it basically how it acts. But remember, it has got one downside. It's got a peripheral anti-estrogenic effect, and therefore it causes thinning on the individual. Now, mind you, this doesn't happen in the first cycle. It always happens when you do back to back. And why it happens is because, this drug has got a longer half-life than letrozole, and therefore it stays in the woman's system longer than letrozole. So, while letrozole be washed up in one cycle, this could have an additive effect when you do it in the second cycle. So therefore, we have to be forewarning. I would always want a woman to take CC one cycle, come on with the washout, and then come on maybe the third month or the fourth month, rather than give it back to back. And the reason is the anti-estrogenic. All sort of protocols, I think we all are so used to with the standard. I just give the standard. There are others like state, step, and luteal given in the books. I really don't prefer them. And the standard is starting from day 2 to day 5. You start with 50, you go up to 150. We don't go to 250. Again, ultrasound monitoring may be needed in the first cycle because you want to determine the dose. Somebody who's a hyperresponder may just need 25 milligrams. So these are some of the protocols I just want to add. I won't spend time here because they are just there. Somebody may like it, but stay step, be it with letrozole or a stay step with clomiphene, actually takes a lot of time. Now, again, remember with clomiphene, the results of ovulation are good, but the pregnancy rates are not very nice. They're not very high, probably because of the anti-estrogenic effect. But what's very important is that you get into 10 to 20% of patients clomiphene resistant. So between CC and letrozole, the resistance is higher. And therefore, this is one of the reasons why we have problems. Also, the other problem besides clomiphene resistance is anti-estrogenic effects. And the pregnancy rates are also lower because they are subclinical pregnancy losses. And these are attributed with the inadequate luteal phase. That is the reason, right? So we would know that there is clomiphene resistant. Causes of CC resistant are obese women, hyperandrogenic, or the ones who are insulin resistant. They are more prone to it. So if you know that there's clomiphene resistance, that means that you gave her up to 150. And despite that, on the follicle monitoring, you did not get ovulation. That means she is CC resistance or CCR. And therefore, what is the treatment option? I would rather move to letrozole faster rather than giving but the book says that you can give them extended doses. Other option is combine clomiphene with metformin, or rather give them metformin if she's an obese PCOS. She's obese, I would rather give her for 1 or 2 cycles metformin, and then rather than realize she could be CC resistant. Yes, gonadotrophins, but you have to be judicious. Laparoscopic ovarian drilling, yes, in books, but no longer the first time because we are getting to do lesser of ovarian drilling. So what about CC failure? That means you got ovulation, but the patient doesn't conceive. That means she ovulates, but she's in that group where despite everything normal, she's not. And therefore, you have to look at causes. But what is my treatment? I am here to find causes, yes. But more than that, give her options. Could I give her moving to letrozole? That is the first line these days, or shifting to an addition of gonadotrophins with clomiphene. Now, I'm moving faster here because I know that there is just 10-15 minutes here with me. So I would say the alternative to CC as an oral is letrozole. And letrozole is now the first line when it comes to, I think I've got the wrong slides here. I have not got the final version. My version has changed. Anyway, This is the older version. Okay, so here is something where I'm so sorry. I think this was I updated my version. Yeah, so I just want to point out, can I exit out from this and get you the newer version? This is not the newer version of my lecture.
No
So
problem.
basically the worry on,
You take a time. Yeah, it's better to go for the new.
because I'm actually taking, what, because can I just stop my this, because,
Yeah. It's better. Yeah.
or let's see. So I'll just come see. I just want to show you the protocols. I just updated this lecture. This is the older version that opened up. So, on the congenital malformation was a very big concern with letrozole. And therefore, we realized, but there's a lot of papers which are coming from the Indian data and also from the Japanese data, which says that letrozole is safe. And therefore, these guidelines clearly say that letrozole, which came with the Big Bang, was out from the market for 10 years, was for that it causes congenital malformation. Now we have enough data to say that no, it is not that risky. So metformin or minoxidil, I just want to add adjuvants. Yes, in obese PCOS we do offer them, and I think the role of metformin is there in the practice committee. We should offer it, but yes, alone metformin versus placebo is not as good. But when it is added with CC, it is definitely a good option. Minoxidil, again, we have data coming from Italy and also from India because it's used as a nutraceutical, not as an ovulation inducing agent. So if we look at the work, it clearly shows that there are a lot of our works also. So I would move here on the second line therapy of gonadotrophins. We use it in patients where we would feel that CC and letrozole are not working. But remember, there are clear baseline evaluation. So you need to have you may probably be able to use letrozole and CC without an HSG. You can give 1 or 3 cycles of simply in ovulation induction without. But when you do a gonadotrophin based stimulation, mind you, it's costly. Therefore, you need to have all these investigation in place. So you should have the tubal status. It's an older technical bulletin, but still hold good. You have to tell the woman that you need to come more frequently, and I would only tell that women who are, affording it, because it's not only on the pocket of the patient, but also she needs more monitoring. This is something which is relevant. So again, on the type of availability, we have urinary and recombinant. I would say that both are equally good. Now, when we are doing, these are all the names that are available in the market. Gonalef is the recombinant version. We have the urinary version. There are whole lots of them. I won't really talk. But whether in a PCOS patient where we use do recombinant versus urinary make a difference, there is data which says there is no difference even in a PCOS. They both work good, but we all are scared and we go in for a recombinant. However, there are a lot of good papers. I just want to share that when you do ovulation induction, remember there is a way in which we start increasing the dose of gonadotropin, which you call as a step-up protocol, which could be conventional versus low dose. And I think I will just take you through it, what it is. So conventional is when you start with NH, and this is what I do it in an hypo. That means you start them with either 75 or 150. You give it for 7 days, then you increase it further for the next 10 days. The idea is monitoring them with ultrasound. And in the first cycle, yes, if you have a patient who could be difficult, you should do an E2. But in women who are HH, I think you are good enough to understand by your wisdom of follicle monitoring only how you go about. And then you look at a follicle which reaches 18 millimeters and you trigger them with HCG. Now, here is the way you do the idea to gradually give it in doses is this, but in a step down, which I really don't believe. I don't give a step down. I thought I could get for postgraduates. I don't think any of us in the fertility specialists are wanting to give a step down. That you give a high dose and then you come down, even for an HH or for any matter. We are not long here. What we are preferring is a low dose step up, which we give in PCOS. We are very fond of this. And this is called as going slow, giving them 37.5 to 75, depending on their BMI, depending on the AFC, and gradually building up to reach a threshold across their FSH window. And then once the threshold is crossed, maintain the window and go on to see a follicle. And once you see a follicle which has crossed to 12 millimeters, you stay at that dose and continue to the same dose. And then you give a trigger when you reach a level of 18 millimeters and trigger them with HCG. So In contrast to this is a chronic ultra low dose, where between the differences here, when you give, you gradually increase from day 3 to day 5 over 2 3 days, a dose of 37.5 to 75. But in a chronic low dose, you go as long as giving the same dose to 5 to 7 days. The advantage is that this is a very good therapy, and I love this to give it in PCOS, but it should only be given by people who understand, who have patience, and also a patient who has to be told that this cycle would go up to 21 to 28 days. We get fantastic results because with this, we land up with just monofollicular, and you don't land up the trouble or the nuances of multiple pregnancy or OHS. And you look at it, the starting dose could be you increase only after 7 days. You know, in a lot of papers by Roy Homburg, who is a pioneer in this therapy, they started as doses as small as 8.3. I haven't started that dose. I start only with 37.5 and go gradually because that dose is not available or difficult for me to titrate. So I just want to tell what are the troubleshooting. The problems could be when you get multifollicular development. I think you should have a low threshold to cancel. I think I have to change this. That's why this is my older version. I won't say 4 to 6. I cancel at anything more than 3. So this is an older version of my slide. I am sorry, I just put this up. Anything more than 3, cancel your cycle. You will not be able to face a triplet and feel sorry. You would not like to. Should you convert to IVF? I don't think in today's day and age, because there can be problems. Why do convert to IVF rather than cancel the cycle is better. The other thing is that I would like to share this combination therapy of combining, clomiphene or letrozole with gonadotropins. As you see, you get lesser side effects, but the algorithm should be in place. And this is how you do it. You can do it starting with clomiphene or letrozole from day 3. And then once you finish, you start adding HMG. With just 2 or 3 shots of 75 IU every day, just means that 7 or 8 day, you call the patient on day 10 and you're happy. Or what I prefer is I just give 150 on day 7 and 150 on day 9 and call her on day 10. So I'm saving her time for injection. So this is what is called a sequential. And then you do ultrasounds, and then you see a follicle more than 18, you trigger, and then you sort of take it from there with timed intercourse or IUI. As compared to conjunctional, where you start giving HMG on the second last day. That means you're overlapping CC letrozole with HMG. Now with this, you have to be a little cautious. You could land up with more follicles as compared to this, because this overlap could lead you to more than 3. So again, it again depends on what recipe you write, how good you are, how good at your handling. Probably the ones where I know that I know her from her clomiphene or letrozole cycle, I know she can be started a little early. If she's a little advanced in age, she's a little obese, I would prefer the conjunction. Of course, very good in CC failures, because instead of jumping straight to gonadotropin, you have saved on the cost. Your cost of the cycle reduces because you're giving lesser gonadotropins. Monitoring is less. Your multiple pregnancy rates are also less. The OHS is lesser, but you could face the music of multiple pregnancies, especially when you do conjunction. So you have to learn this. Now, do you add antagonists? Somebody would ask me in IUI. Yes, there is a group of clinicians who like to use antagonists, especially in women who are PCOS, where they have got high LH levels. Baseline LH are high. So, you can do it, monitor them by giving gonadotropins, and call them the day when their follicle reaches 12 or 14. You could just add 1 shot of antagonist and then take it from there. Because, women who are prone to have an LH surge are either who are elderly, like more than 35 years, or the ones who are having PCOS. So that is my, here. But just want to complete what are the downsides or nuances of gonadotropins alone. High risk of multiple pregnancies and you look at letrozole, so much less as compared to gonadotropins. So you have to know to learn when to cancel cycles. The other complication could be OHSS, which could be, I would say, a dreaded complication, which we should fear. And again, you should have low threshold, because PCOS, especially when they are brittle, when they are having high AMH levels, particularly the ones who have AMH levels more than 7 nanograms, are very prone. So I would rather go with the chronic step up. So in the chronic step up low dose protocol, you can avoid this complication. So in summary, I would say your choice would be oral. The safest is letrozole first line, in only gonadotrophins would be preferred when I'm doing an IUI cycle with unexplained or endometriosis. And I would say my cancellation to threshold is when I have more than 3 or when I have E2 levels which are more than. And my goal in an anovulatory or for anybody should be a monofollicular development with this thing, a singleton pregnancy. That should be our goal. So can we go on? I think I can skip the IU, and I thought, let me talk on IVF. Is it okay for me to go to IVF?
Yeah, better. That is needed.
So I'm apologizing, but I went on to the wrong slide on the thing. But I think I would jump to the IVF first here, which is important. Can you see the slide on IVF here? Yeah. Can you see the slides on IVF?
See.
Yeah. So let's move on quickly because IUI is something I thought we can talk in discussion part, but definitely I won't tell you in details. These are the women who clearly need it. If there's a tubal block, tubal disease, genital tuberculosis causing damage, unexplained, yes. I have tried IUIs, and after 3 IUIs and unexplained, if I fail, I would go. If there is a grade 4 endometriosis, I'm not going to waste time. I will go straight. PCOS, yes, not the first line at all, but the third line. And for me, the PCOS first line is always weight loss. Second line are drugs, depending on ovulation induction or going in. So I would rather go for as a last choice in PCOS. Women who are having poor ovarian reserves, who are at risk of premature ovarian failure, especially the ones like borderline reserves, I'm not going to wait. I'm going to take them earlier for IVF. And in today's day, I think 40% of our IVF clients are ones who have diminished ovarian reserve. Of course, male factor, I would go in straight. So what do you really do in IVF? If you've taken a decision, what should be your basic evaluation? And I think a pre-IVF should always look at ovarian reserve. Why I need an AMH? Why I need an AFC? Because I have to take a decision on what protocol I'm doing. I need to evaluate because I think it's not just creating a good seed, as in a good embryo. How good is the soil? Because at the end of the day, I want a baby. The woman is interested. If her lining is not good, if her endometrium doesn't take up the challenge to come up to at least 7.5 or 8 millimeters, be it in a fresh or frozen cycle, it's needless. So a uterine evaluation to rule out whether she has submucous fibroids, she has adenomyosis. Very important to screen because we are going to handle gametes in the lab. If it's an HIV positive woman, I have to be different. I'm freezing the embryos. I have to make sure that there is an HBsAg screening, including an and the Hep C. Of course, because there may be anesthesia in some units, short anesthesia, we would do some basic investigation. For the male, yes, I need a detailed semen analysis because that will be the cornerstone to take a decision whether the couple needs ICSI or needs anything beyond ICSI also. We call it PICSI, or we need, something like oocyte activation if there are other problems. But a semen culture may not be a standard in most labs, but we do it in our lab. This is our protocol because, if there is infection, probably we could treat, or we could do a different method of collection of semen. Again, semen infection stream common for both couples. But if there is microdeletion, only if the semen counts are lesser than 1 million. So what is the whole process? The whole process involves stimulating the ovaries because we're wanting more oocytes. We're not wanting 1, 2 here. We're wanting at least 10, 12 oocytes, but certainly not more than 15 or 20. And then we're following them up with the stimulation protocols, whatever we do, depending on the patient profile, the profile of the woman. Then when the woman is ready, that means the follicles, at least 3 follicles have reached more than 80 millimeters, we'll do a trigger, and I'll show you on that how we do. We do a collection of the eggs, which is done under a short anesthesia or under even local, in some labs do it, some units do it. We do the sperm retrieval, that means collection of the sperms if it's normal semen parameters, put them to standard fertilization in IVF, and then look at the embryo for a fertilization check the next day, then culture this embryo, which is fertilized on a day 1 to take them up to day 5 as an blastocyst. So these are all the stimulation protocols, which would actually mean combination of agonist or antagonist. I won't talk of minimal stimulation here because I know you're talking to postgraduate. I would definitely talk of progesterone primed ovarian stimulation, which is getting very common with us, and a little bit of dual stimulation. So on the agonist, we have all those ones, which is the long agonist, to the ultra short, I would say that we all in the long protocol use the mid-luteal start. This is the very popular one. I won't talk on the others, the stop agonist, reduced dose, they're all there. But the mid-luteal is the gold standard as compared to the antagonist, which is a shorter protocol where we do multiple doses. That means we're giving multiple doses of antagonist in the flexible or a fixed start. And I will tell you what it is. Again, the agonist protocols are all here. I won't waste time here on these all protocols, but we use, I won't talk on these details, but we look at the luteal phase start. That means we go on day 21 of the previous cycle. We start giving her injections of GnRH agonist, and then we continue the GnRH agonist till she's ready for the trigger. This is the most common. As compared to the others, which we're not using, the one I thought I could touch, if there are questions, is the microdose flare, which you use in women with poor ovarian response. My unit uses this quite often. Now, the agonist protocol you see, you started her on a day 21 with the GnRH agonist in 0.5 milligrams per day. It is variable between 1 to 0.5. We have now switched to 0.5. We are happy. Earlier, we used to give 1 milligram. And then once she's down-regulated, that means she gets her periods, we check whether she is down-regulated, as in whether her E2 levels are good, lesser than 30, LH is low, there are no cysts, and the endometrium is silent. That means the ovaries are silent. We've down-regulated the ovaries, we've suppressed the ovaries, and from that day, we start giving them gonadotrophins, depending on her age, her BMI, her follicle counts. We go and take both these drugs together, and we call them for serial follicle monitoring. The first TVS is done on a day 6. That means the 6th day of stimulation, which may not be the 6th day of a period. That means she gets the injections for the 6th day, and some people call it on day 7. That means 7 days. On some, we call it on the day 6. And then we call them serially depending on how she behaves. And then once she's ready, that means more than 3 follicles. This is the book says 17, I'm happy to trigger them at 18. And then we do an ovum pickup, 36 hours, and then grow the embryos in the culture to embryo transfer. Now, I won't take this because of paucity of time. I will come straight to the antagonist. Antagonist is a shorter protocol. Now, who are the candidates for agonists? Who are good candidates? Certainly the ones who have endometriosis, who have adenomyosis. They do better because in today's day and age, all of us are relying on the antagonist. But if you ask me personally, I am a big fan of agonist cycle. It is still my gold standard. In a normogonadotrophic, non-PCOS patient, I would always prefer it. The reason why patients don't like it is longer. If you compare it with the antagonist, it goes longer because you're giving almost 1 week extra starting from day 21 of the previous cycle. So you take 8 days extra, but certainly of value because you get a very, very homogeneous egg. So what are the advantage? You get a very homogeneous or a synchronous cohort. That is the reason. So I may get maybe 2 or 3 extra eggs as compared to antagonist. So I would definitely like it because every egg matters. You get more oocytes, you get more embryos, and surplus embryos for prior preservation. But the disadvantage is it's longer. There may be a tendency to cyst formation when we have kind of recipes how we avoid this also. Only thing is the woman may be at increased risk for OHS. But why should I get OHS if I'm selecting my woman rightly? I'm not giving in a PCOS. I'm not giving in a hyperresponder. I'm not giving in a woman who has got very high OHS. Only thing is it has got longer duration. And because it's got longer duration, it gets costly because the patient has to, come to your hospital more. Now, the antagonist protocols are the ones which are most liked by all of us. The antagonist is, again, why are we giving these agonist antagonists? I'm sorry to tell you that, I forgot to tell you, the ideology is that when you do controlled ovarian stimulation, you're controlling the hypothalamus-pituitary ovarian axis. You are controlling by suppressing the LH so that the endogenous LH is countered. And the endogenous LH can be countered by either agonist, which is like maybe lupride, triptorelin, boostulin, whatever drug. And therefore, we give it, or we could use antagonist. Now, antagonists, again, act to suppress the LH. The good bit is that they have an onset of action as soon as 6 hours. Whereas if you realize your pharmacology, an agonist will have an initial flare effect, and then it will take time. Therefore, they take longer. So here, what is a good thing is the antagonist can be started immediately when we feel that the LH is going to begin to rise. And when does the LH begin to rise? When the follicles start growing from 12 to 14 millimeters, right? So that's the reason why we add, because some bit of LH is always needed. So when we start stimulation from day 2, we would definitely give gonadotrophins, but that LH is actually needed for the follicles to grow. So what we do in our understanding, the time when we feel that the LH is going to begin to rise, that is the guideline says, then we add the antagonist, and which is given preferably in a fixed start from a day 6 or a flexible start, that is when the follicle is going from 12 to 14 millimeters. So we have got 2 products in India available as cetrotide, or the one is ganirelix. They both come as similar doses. The duration of action can go up to 24 hours. So therefore, you have to make sure that you give an antagonist at a fixed time. If you give an antagonist in the morning, then we give the antagonist the next day in the morning in the shift. The big recipe make is that you should keep a gap of at least, ideally at least 10 hours, but a minimum of 7 to 10 hours between the two. Can't give them very close. Now, who are the candidates? I would say who are poor responders because you want the cycle to be short, or who are hyper responders. Definitely, if I have a PCOS, I will try nothing but an antagonist, especially when there's a pure male factor and she's a young woman. I know she'll go faster. And the preferred protocol when we get cancer survivors, I do get a breast cancer patient, she doesn't have time, I will just go and take her for starting the antagonist protocol in any phase. Now, again, why do we call it fixed start? Fixed because we are giving the antagonist on day 6 of the stimulation, as compared to flexible, which we do when the lead follicle is at least 12 millimeters and the estradiol levels are at least, beyond 250. Never give it, lesser than 250 to 500. The ways you start on the day 2 of the period, start the gonadotrophin, which could be either urinary or your guide HMG or a gonalef. You started, go on the 5th day, you do a scan. That means you've checked and you find that yes, the follicle is 12. You would give the antagonist on that day added, or otherwise in the fixed start, you don't call them, you just give the antagonist on day 6. But all of us are preferring to do a flexible because we know that we will definitely look, and she will never be ready here. She may be ready with a follicle on a day 6 or maybe on a day 7. Likewise, when they are ready, 3 follicles more than 18, we trigger them with HCG and then do an ovum pickup 36 hours later and take them. So definite advantages is it's a shorter duration. Beautiful thing is there is a reduced risk of OHS. Don't think OHS will not happen. It can still happen, but because it's shorter, the duration of your gonadotrophin is lesser. The cyst formation is this. It's less. It's patient friendly. But remember, there can be a patient where you can still have an escape of the LH in a woman who is poor responder. She can still escape it. There can be marked LH separation also. And also, you don't get a very synchronous cohort. You always get an asynchronous cohort. And there are a lot of recipes, again, I will not be able to cover here. RDM students know what they especially are their full, chapters or seminars on how to make them, more coherent, more congruous, or more, synchronous cohorts. And therefore, we suffer this problem, which we do by giving estrogen priming, progesterone priming, and the likes. I just want to touch on this protocol, which is a new protocol for our postgraduates, also comes as a short note on dual stimulation, where we give one cycle, do a pickup, then antagonist, and after the pickup, we stop it and do a second cycle. Now, this is based on the ideology that there is not one follicular wave. We've always understood that there's only one wave in which a woman gets one cohort of follicles. Now we realize that multifollicular development, and there could be even 2 to 3 waves of follicular genesis in a single woman. And therefore, we do a pickup again. After one pickup, we start stimulating. And this is what is called as a dual stimulation. We can do 2 pickups. Which are these patients? These are patients where we know we've got poor response. We are expecting a poor response. So what we'll do, we'll pick up the egg, create embryos, start the next phase, depending on her, profile, and then freeze the embryos from here, create embryos from here, pick up the eggs, create embryos. But certainly this woman will not go for a fresh embryo transfer. She will definitely go for a frozen embryo transfer. Now, I wanted to tell, when we are giving agonist or antagonist, what are we doing? We're trying to suppress the LH. Is there any other drug which can be used for suppression? Yes, there is medroxyprogesterone, or rather progesterones, even dydrogesterone can be used to suppress the LH. And trust me, we are using this, in a standard ovarian stimulation. You see, you started giving her on the second or third day gonadotropins, then on the day, 1, 2, 3, 4, 5, 6, depending on the flexible starting giving her second dose of injection, which is antagonist, doing an ovum pickup, and then an embryo transfer. But in a progesterone primed ovarian stimulation, what you do, you start with gonadotropins, and the same day you start giving them medroxyprogesterone acetate in the doses of 10 milligram twice daily. What does medroxyprogesterone do? It suppresses the LH, and there's now lots of papers which say that MPA works as good as an antagonist. But what's the big advantage? It is so much cheap, it is so much friendly. The patient is just taking injection one day in comparison to 2 injections, which she's taking with an antagonist. I use this protocol when I do a dual stimulation, where I do the first stimulation with antagonist. I want to save cost to my unit, to my lab, start the gonadotropins, and on this, they start MPA. Also, a lot of us who are doing donor oocyte cycles, where the donor is a young woman, I would rather use the PPOS because I'm saving cost and I'm making it a user-friendly, because a donor would not like 2 injections. She's happier taking 1 injection. So that is the group of patient. And also a lot of PPS, when we get a cancer patient, a lot of data where a cancer survivor who's wanting to save her, freeze her, oocytes or create embryos before she goes for chemoradiation, we do a PPS-based stimulation. Now, I would say, what is the next step of triggering? The book says 3 follicles more than 17, or the estradiol more than 1,000, or 1 to 2. I think I would rather say when we have more than 3 follicles of 17 to 18, I'm happier. You could give injection either 10,000 IUI of HCG, which is the triggering injection, or you could give in recombinant. The other thing to trigger could be agonist. Now, agonist triggers are needed when we want to avoid OHSS, as in a patient who is a hyperresponder, because that decreases the risk of OHSS in IVF. So what is our take? How do we decide what protocol we are going to use? What is going to be the best test is her ovarian reserve. And for me, biological age. If I get a young patient who's like 26, 27, I don't even bother. I just do a FCN and say, let's start. That is what we do in donors. So the female age is one of the best predictors for somebody to tell what is her chance of having a live birth, because that is the young one who will not give me not just more eggs, she'll give me good quality oocytes, and good quality oocytes mean good quality embryos. So very important for us that ORTs or ovarian reserves do tell us, but do not tell us that a low AMH is not to be offered. I would say we do counsel them. Your chance of having good eggs, good embryos is less, but it didn't say that you are not going to take an IVF. A lot of times, patient come and tell me, because my AMH is 0.9, they told me, aapka IVF nahi karenge. No, that's not the way. We will still give them options. So again, as I said, what will be my starting dose of gonadotropins will be individualized depending on what is her age, what is her previous response. Again, if she's a high, I look at all the papers. If she is responding well to a CC letrozole, I think that is also a good take, that I will give her a normal doses. To somebody who I feel in a previous cycle has not done well, even with some other unit, I will change my dosages. So hyporesponders would be the ones who would basically need higher doses as compared to a PCOS, where I would get a hyporesponder. Now, is there an association? What is a number we would want? We certainly, and these are all numbers which have come from landmark papers from Sheshkamal Sankara. What is our target? We want to get anything between 8 to 15 oocytes to get pregnancy rates. These are figures. They said if you give more than 20 eggs, the pregnancy rates decline. Why? Because you're creating a hyperestrogenic state, which may not be good for the endometrium. So there is definitely a link. And what should be the optimal number? Anything within 15 is a good number. Anything lesser than 5 is not good. So how do you say who's a hyperresponder, who's a lean woman, who's a PCOS, who's younger in age? I won't say younger than 35, I would say younger than 30 in India, who's got high AMHs, who got high FCs beyond 24, and who's given a previous history of poor response. So that is the way we would do an IVF cycle. Now, on the egg retrieval, we would give an injection HCG, which could be recombinant or a urinary, and we do a transvaginal guided pickup under a short anesthesia, routine antibiotic prophylaxis, routinely not given, but somebody says, yes, I give one shot, okay, it's fine. But if you're dealing with the woman with endometriomas, yes, it's good to give an antibiotic. Now, after you retrieve the egg, what next? You have to do a fertilization. How will you attain fertilization? You do it if you have sperms in ejaculate, which are obtained after masturbation. Definitely don't ask the man to abstain longer because you could get a poor quality, of sperms. If it's an azoospermia, you could do obstructive, and in obstructive, now you're going to do PISA, which is the best. We do mise, which is microsurgical if we don't get sperms on PESA. So, that's the way you do it in the flow for an obstructive azoospermia. And this is the procedure with PD. PISA is simple. You just go to the epididymis with the butterfly and come out. A lot of people would do TEFNA, but then TEFNA is a little more. That means taking up aspiration. MISA is definitely microsurgical. It needs a small incision in the scrotum under anesthesia, and it's something when the PISA fails. So when we're doing a surgical, now you should know why are we doing these surgical sperm retrievals, because we know that the man is not able to give sperms on ejaculate, i.e. has got azoospermia. So when you do a surgical sperm retrieval, remember your option of fertilizing the egg is always ICSI. But then there'll be indication other than surgical sperm retrieval, as in we get somebody whose sperm count is low, as in less than 1 million, or who's got astenosospermia. I know the motility is low, or for that matter, severe oats. So isolated ones are lesser. Also, some units in France and Europe which are testing antibodies because they're not offering ICSI routinely. In our setups, we don't do this. Yes, if it's a surgically retrieved sperm, definitely ICSI. If there is a woman who in a previous cycle had a failure fertilization with a standard IVF, then you do ICSI. And the procedure is simple. You take the sperm, which is retrieved or picked up, taken up in a needle. It's all done under a micro manipulation in the stereozoom microscope. The eggs are injected in, and you are happy to see the heart sign, and you come out with your thing. And each egg is injected with a separate, the same needle is there. The embryologist manipulates, picks up, breaks the tail, sucks in it, sucks the sperms and injects it. So what you do, you check in for the embryo, and this is the day 1 when you see two pronuclei, which is the pronuclear body with the second polar body extruded. Because the egg will have one polar body, the second polar body extruded is a happy sign. That means it's fertilized. It's day 1. The day 0 is when you retrieve the 2-cell stage, and then you move on to the 4-cell stage, 8-cell stage, which is a day 3 cell stage. We don't have a 2-cell stage because we look at day 1 and then we go on to day 2. Again, I can't teach you the embryology bit in this small lecture. And then we go on to the day 4, which is a morula again. The best is a day 5 or a day 6 when you get an expanded. Now, we've got a lot of scoring systems. The Gardner scoring applies for the blastocyst, whereas we have the other scoring systems for the day 3. Not that we would like to put all embryos, we would want to put them on a day 3. And this is how we call as a cleavage stage embryo. But if we feel the embryo is good enough, your lab has got good condition, we all prefer to take it to a blastocyst, which is a day 5. You can see an expanded blastocyst with thin ectoderm, a good inner cell mass, and this is the one where we want. But many times when the quality of embryo is not good, I'm very scared. I know my embryos will not go. It's not a grade 1 embryo. It is one which has got a lot of, granulations, one which has got unequal blastomeres. It's a grade 2. I would rather transfer them on a day 3. Now, this is how we embryo transfer. We do the embryo transfer under ultrasound guidance on a day 5, and you can see the air bubble press, because what is this? The catheter is, we do a preload technique in which we load the, embryo is cushioned, embryo in the transfer fluid or the transfer media is cushioned between 2 air bubbles. So there's a little of fluid, the air, the embryo with the culture media, and then the air column, and then that's pushed. That's what your embryologist will get under ultrasound guidance with a full bladder. You gently manipulate and put this embryo and reach in the mid-level of the cavity, and then you push gently We use the standard Cook's embryo catheters, and the air bubbles are seen. And that's where we want to put in the catheter at least 1.2 to 1.8 centimeters below the fundus. So we measure it, and your catheter should be in the mid cavity, because there's data which says that this placement is best. I just thought that I can't end the lecture without talking about pre-implantation genetic testing. That pre-genetic testing means you're testing that embryo for any abnormality by genetic test. It could be for aneuploidies or for structural, malformations, which you call as PGT SR or PGTM for monogenic disorders. And what we do that we can analyze this right from the oocyte states to the blastocyst. Now, this is how it came to testing polar bodies, to testing embryos. In a country like Germany, today also they're testing it from oocyte. But most labs internationally have moved to take the genetic material from the blastocyst, because that's the best and the easiest to determine the genetic abnormality. Aneuploidy can affect embryos, particularly women who are advanced stage. You see that up to 40 to 50% of these embryos coming from women beyond 38 years would be aneuploid. And they will just give not only poor implantation or poor pregnancies, but also high miscarriage rate. So therefore, these are women who are indicated to aneuploidy screen. So just want to say that we have moved in the current, we call it consortium to PG2. We have used them from the word PGS to PGT. That means pre-implantation genetic diagnosis. And what is the difference? This is just the difference in the terminology. Also, we should remember that we've also moved in the technology where we're using RACGH. We have moved to the next generation sequencing, NGS, to understand. And I would just say that this is the way PGTA means aneuploidy screen, which would do for women, where we're looking up the constitution of the 46 chromosomes for any aneuploidy, and the indications are advanced maternal age, severe male factor, because we know that the severe male factor with severe oats can contribute to an aneuploid embryo. Also, when we have recurrent implantation failures, then these are couples where we should offer PGTA, as against to somebody who has got a monogenic disorder, like cystic fibrosis. There's BRCA mutations. These are diseases where I would do just to make sure that I'm putting back an embryo which is normal. To structural, we call it PGT-SR. So in the realms of embryology, what happens is you've taken just from the cleavage embryo 1 or 2 blastomeres. And from a blastocyst, which is a day 5, I've picked anything from 3 to 5 trophoectodermal cells. This technique of embryo biopsy is a very, very high-tech procedure done by a good embryologist who knows the micromanipulation techniques, picks up these cells, freezes them, takes it to a very nice transport media, and then in those very fine, there is a very fine SOP, which I don't think I can teach you in this thing, but this is then, there is not only a method of picking the embryos, but there's also a method of transferring these cells after biopsy and then sent to labs which do use the platform of NGS and identify. Now, what happens to these embryos? The result won't come that day. All these embryos are frozen, and they're frozen individually. When the report comes after 48 hours, that embryo 1 and embryo 5 are abnormal, we discard them. And embryo 3, 4, and 7, or whatever are good, we continue. So you can never put back in a fresh cycle, but you could put back in a frozen cycle. That means the embryos are frozen and they're cryopreserved and taken, and the frozen thawed cycle, the embryos are put back. The reason is that you are putting back the right kind of embryo, and therefore the outcome would be better. Does it improve pregnancy rate? No. PGT does not improve pregnancy rate, but it is telling you that it is putting the embryo which is of a good and the right quality. So there is a lot of controversy. A lot of people are given this hope that it'll improve your live birth rate. It does not. It just ensures the right kind of embryo has gone into the right individual. I just can't stop talking about one complication which you all read in IVF is OHSS, which is a self-induced iatrogenic complication. We know there's an early onset which develops within 7 days of the trigger, in contrast to something which happens after 7 days. Remember, the nuances of OHSS is because HCG is in excess. And this could be because the trigger is coming from the exogenous HCG, whereas in the late onset, it is because she's becoming pregnant and the endogenous HCG is causing. It's a leaky syndrome because there is production of increased amounts of VEGF and all these angiogenic factors which activate the RAS activation, intraovarian system goes, it's something like dengue, or for that matter, even the COVID, the leaky syndrome, which causes the blood vessels, the intravascular compartment to push fluid into the lungs, to the pleural cavity, to the peritoneal cavity. The woman comes with symptoms right from mild vomiting, nausea, bloating to severe critical OHSS, where she will have tense ascites, hematocrit rises, and lo and behold, I don't think anybody should have. I'll just share you. We have one patient referred to us last week with critical OHSS who's suffering from anuria. Her kidneys are out, and she's had 4 dialysis in last 1 week. She has resumed and got all her hyponatremia and hyperkalemia corrected, but her kidneys are still not opening. So in today's day and age, she was a lean PCOS. We've seen such a kind of referral happen after ages, but all of us should be very cautious that we have to do an IVF at the cost of no OHSS. That's an OHSS-free IVF. So these are all the methods. You should use your right protocol, use trigger with agonist, and freeze also. If you have a patient who has a risk, I would rather do a agonist trigger and freeze all rather than take. And before an IVF, I should know that I should give her a low dose FSH. Metformin is a very good drug. So all our lean PCOS or PCOS women who are at risk, we don't take them for IVF. We give them for at least 8 to 12 weeks of metformin and then take form, because this reduces. Now, these are all the some symptoms that can develop, and therefore this is something which you should take in the history of a woman who is suspected to go for this thing. Again, I don't think we should have time. We don't have time. We'll just say OHSS is something which is dreaded, and we should believe that we should avoid it. The management of mild OHSS can be from the outpatient, but if she's anything moderate or going to severe, we should just admit them. And if you can understand the criticality, you would need to do not just their hematocrit, you should do their TLC, their platelets, blood urea, their creatinine values, get their liver function test done. Do put them on a strict output monitoring, because oliguria can be very, very tricky. Make sure you give them the right fluid management. Also important is to tap their ascitic fluid, because this could be relieving the pressure on the renal vessels and not let them develop oliguria or anuria. So this is the management, fluid management, assessment of their input outputs. Hematocrit, they're in pain because of distension. And yes, in critical cases, we'd even need to give them low dose molecular weight, low LMWH, but these are critical cases. So I just end my talk here, but because I think we are past 8 o'clock, and if you would agree, I'd be happy to take questions from you.
Yes, thank you, ma'am.
That was such a non-stop rapid firing talk, and so much for the postgraduates. They'll be really scared. This much of problems and infertility, and lots. Now, how much ever they listen to, it's really so much advanced has also happened, and the OHS is repeated short notes for them. So they should really know them, and then this newer things are really good. Metformin has come in a long way for prevention of OHSS. Earlier they were telling about cabergoline. Now you were telling about metformin. That is also one take-home point for the PGs, and also the antagonist protocol and the agonist trigger. All those things are really, they would have enjoyed your talk, and with flooded with more information, and it was really good, Nina. I don't have words to say, and Mala was there also, and she knows, and she'll be listening to you. And Mala, any comments on this?
Questions.
Yeah, questions we can take up. Only 4 or 5 questions are there.
Yeah.
Yes,
I
ma'am.
think some questions are answered by Sonia.
Sonia has answered
Sonia is my
that.
colleague who does a lot of hypoxia there.
They were asking how much saline to be instilled for the hypoxia.
Yeah, so you know what we do? I'll just share you. When we do a hypoxia, or for that matter, saline sonosalpinography, we first use a pediatric Foley's. We don't use a standard Foley's. We'd like to use a Foley's which is That's what we prefer. And anything between 2 to 5 cc is enough. We don't need to go beyond that. And name the medium of the liquid use. I've already mentioned it in my slide. I can share it.
Yeah, it's a foam
It's
kind of a thing. Yeah.
Yeah,
So
all
it's
the-
there, and
It's costly? How much
it's
is the cost?
costly. Sonia can, because what is, we just got it in a tender process. I think it's costing us something like 7,000-8,000 rupees.
Okay.
Oh.
That's it. It's on a tender, so but maybe the market is there. But I know that the high 4C is something close to around 20. We don't get it in India, but high 4C, the newer one which we're getting XXFM is something like 70,000 to the hospital. So we just took it as a thesis, as a quality initiative to really see is it making an improvement, because why? Because our patient takes 3 trips. She comes for a baseline evaluation, then takes. So we wanted to look at the feedback and then do a patient and then make it, because this is coming as free of cost to the patient. She's not spending money. So that's why we took this as an initiative.
Then
Hello, Nina. It was a wonderful talk. I just wanted to ask one thing. Are you able to hear me, Nina?
Yes, ma'am. Yes.
ma'am.
Yeah. Very recently, there was I read somewhere there is a concept has come of no abstinence, stat sample of semen. So that is what I just, because I've not read it.
I can share you. In fact, I didn't want to get it for my postgraduates. In fact, I would say,
but it was for us.
and I will share this. There is a paper which is a brilliant paper in fertility study, but none other than my dear friend Mohan Kamath. And what he did, it was a thesis project. What he did, he looked at semen parameters right from volume, motility, morphology, and all the parameters on the WHO in men who came between 1, 2, 3 to 7 days of abstinence, right? So what they found that the abstinent duration did not make any difference in the outcome. So this was one thing, because, and this paper is already there. I think it is in there, a paper in 2017 to 2018 article. If you type in your PubMed, Mohan Kamath, semen abstinence, and the paper will come. So Mohan has already documented this in a brilliant paper that the days of abstinence does not
Can you
matter.
post that link of that paper? Can you post
Yes, I can post it. So you just put Kamath Mohan Kamath, because Mohan Kamath is from Vellore, and he did it. And the girl who was actually our postgraduate, she had done this thesis with him as a part of her DM. And when they found that so why this he did it, and it's a very common thing that men say we may not be able to have so much of abstinence. So therefore, that was a thought. And also we wanted to really know, why are we accepting some things? Are they gospel to the biblical truth? So, what with our IVF units, when we have patients who are coming, we also feel that we want to have a good semen quality, maybe 1 day of abstinence, or we will say masturbate and come, because, she's undergoing IVF. So we'd rather say, okay, the day she triggers, we'll say you ejaculate and come, because the next is just 1 day gap, which is this is our SOP. So this is one recipe I want to share. We always get a better quality as compared to the longer the absence. So his paper is already there, which has already, spoken about it.
So in the next Dr. Sonia has answered all the HICOC questions.
I was so happy Sonia was answering while I was taking. She's my unit colleague. She's an associate professor who does a lot of these things.
She has told about foam also, XM foam, FDA approved on, it's called HIFO-C.
Yes, HIFO-C. Except for the foam. And HIFO-C is a standard in France. When I was last year in France, I was impressed that they are such a rich unit, because every IVF is free, egg freezing, social egg freezing is free. And they said, we don't use HIFO-C, we use HIFO-C. And when I translated that money, euros in Indian money, it came as 30,000. So I said, my typical evaluation will be like, because they are a rich country. So, their health budget is so good that they can afford a HIFO-C. Postgraduates don't even know HSG. That was what I was learning from them.
Dr. Akanksha has asked, when we try alternate days for timed intercourse, the gap between the two samples is less than 48 hours. Does it affect 7 parameters? Just now,
I've already answered, but Dr. Kiran Pandey's answer, and when you tell time intercourse, you should not tell alternate day, you should tell every day. In fact, I don't have time for an ovulation induction, IUI wala chap thing. I'll tell you, there's another tip that I want to give, and we see this improves. When the day we do an IUI, we always tell the couple to have sex. it also improves pregnancy chances.
Yeah.
Because, there's something that a lot of people say, why are you telling it that day? We're just increasing the probability, because though he's given the sample in the morning, he still gets, and I've seen these patients do well. So therefore, I don't think that we should say alternate day. When they're going for a time intercourse, if they can possibly do every day, it'll be a good option.
Have you ever encountered ovarian hyperstimulation syndrome in agonist trigger?
Agonist trigger, yes, I have. In fact, the one that I've got in my ICU referred, don't tell, she's come from a tier 2 or a tier 3 city, is a girl who is 26, 27, a lean PCOS, who has got triptorelin trigger. So learn one thing, that agonist trigger doesn't say that you will not have OHSS. You can still have OHSS. If you read the works of Peter Homadine in human reproduction, beginning from 2013 until 2016-17, he says it reduces but doesn't make it zero. In the randomized trial where they gave both agonist versus the standard trigger, they had lesser OHSS, but they still had OHSS.
Yeah.
Also, the intensity of OHSS might decrease, but you cannot make an OHSS free completely by giving an agonist trigger. So you have to have pre, during gonadotrophins, during trigger, and also post. I know that I used to give a lot of cabergoline off late because there's little evidence. We stopped giving antagonists. I'll tell you one thing which again helps me. Another recipe. The day you do a pickup and you feel she could give her, continuously antag for 2 to 3 days. You know what you do? You are reducing her VEGF.
Yeah.
You can even give her.
I give even heparin also, even in spite, as you very rightly mentioned, even in spite of agonist trigger, they do hyperstimulate.
Yeah.
So when you have more than 15 to 20 follicles and you're going to freeze these follicles, but still if you want to, be double sure that she doesn't, end up in OHS, I give a heparin for 5 days, and of course continue the and the antagonist also for 3 days. So with that they settle down very beautifully, because it is such a headache if you have just one case of OHS, as we know they are
The reputation is spoiled. You may have done. And another tip I tell,
the new ART we are not supposed to be having, because as
is free clinic.
we are supposed to only stimulating to such an extent, we get only 7 to 8 oocytes, which is practically impossible. But it has to be hyperstimulation free clinic. That is what the new ART rule says. So we have to be very, very careful while we are, like you had a very recent case, no, madam, like where the patient had even kidney failure.
Yes.
In this current scenario of ANTA, I think we should not end up having any kind of, eventuality like that. That is a very important message. I think our junior colleagues should understand, like our PGs who are watching now should understand, and that is.
And you know what? I didn't have time. I got it in the other version. Even, when you give metformin, it helps. Again, we've done one randomized trial, which is also published. We did myosinol versus pure myosinol versus metformin. We found myosinol also reduces the risk of OHSS, is as good as metformin. And another tip that I give to all juniors who are in our DM program, we do a 3-year DM in reproductive medicine. When you are looking at OHS, just don't look at follicles which are dominant follicles. Go even to the 10, 12. The smaller ones are the nuisance. The smaller ones are trouble.
Yeah.
When you don't get egg, prick them, because you aspirate them, they are the ones which. So make sure that you have not just aspirated the 15 and above, go on to the ones which have been 10 to 12. So that is also another take, which I feel reduces your risk of OHS.
What about coasting, Nina?
Yes, I tell you, if you look at literature, doesn't support, but I believe in coasting. Coasting doesn't mean, so in the real world, coasting doesn't mean stopping. I start reducing the dose. That is also coasting. And another thing I would say, I would coast when I would see a little rise in estrogens. And my estrogen, if it's coming with a rising progesterone, is forewarning me. Because many times the progesterone also is giving me a hint. So I start reducing my dose. So coasting means not just stopping, but even reducing. So I believe that really helps. It helps us.
Yeah. Usually that's with the freeze-all technique, and definitely our OHSs, we should not have any OHS at all. And what I would definitely suggest is aspirate all the follicles and aspirate even the POD fluid. So many times you have a very high POD fluid and you just aspirate everything. Sometimes you might find eggs, sometimes you might find GVs or M1s, doesn't matter. Just aspirate everything and you just make sure, actually it helps in a lot of symptoms also. post, even though she does not develop florid OHSs, in symptomatology, she's very comfortable if we aspirate the POD fluids.
Yes,
And
yes.
thank you so much, madam. It was an excellent session from A to Z of infertility. Everything was covered. No stone was left unturned in this lecture, and we had a nice discussion. Your male infertility topics was very good. I really enjoyed.
Really
it was
good,
very, very straightforward. Nudge. It was too good. And you really touched, a lot of controversy about antioxidants. You touched upon that also. So everything was really very good, madam. Thank you so much.
And in case the postgraduate wants the PPT, I can even share the one which I didn't cover IUI. So, it can be used for them. I'm happy to share the slides. I can share
you can send it across, madam. You can send it across.
It was a very excellent talk, madam, and very significant, because on being a World IVF Day, I think our President, Dr. Vijaya, madam, has chosen a very, very appropriate topic for this, and a great speaker also. So it is very, very, encouraging, must be very encouraging for our PGs, and they would have really got motivated. Now, I think with the rate in which the infertility is going up, every practitioner should be, well versed with the infertility workup and also the management. And you have very beautifully highlighted everything. So basically, the endocrinology, if you are thorough, I think you'll be able to manage infertility. So that is the most strong foundation as a PG they should learn now. The endocrinology, right from what the brain does to the ovary and what the ovary does to the uterus. If they are thorough, they know how to understand the infertility management, and they can, with a little bit of training and other things, it will be nice to manage infertility. And you have beautifully covered all the various aspects of infertility, right from the basic to the advanced, to PGD, PGF, and everything, and how to manage complications and how to avoid complications, which is also very, very crucial. So I think the PGs would have tremendously benefited out of this entire session. And we like to thank Dr. Nina and entire the FOXY committee, and also Dr. Kiran Pandey for this excellent initiative. Of course, AKSHARAM, we are doing it every month to focus on single aspect, which is a very, very novel thing. And also, I think the PGs are going to be very thankful for this lecture series. So thank you so much, madam.
Right. Thank you.
Yeah, Dana, you want to
Thank
add
you.
on anything?
Good night,
Dr.
ma'am.
Dana?
Good night. Thank you so much.
Muted, you're muted. Unmute.
Thank you, ma'am. Thank you very much,
Yeah,
ma'am.
thank you,
ma'am.
Nina. Thank you so much.
Thank you so much.
Taken more than 2.5 hours.
Yeah, I think we should
Non-stop.
close it.
Non-stop. Yeah. Let the PGs relax, and it's very good. Yeah, thank you so much.
Madam, you
Kiran,
did complete justice to the
Thank you,
topic.
Nita. Thank you, Mala. Thank you, everybody. Thank you, Dr.
Thank you, Kiran. Bye.
Thank you.
Thank you, Dr. Kiran. Thank you.
Yeah,
You
thank
did
you
complete
so
justice
much.
to the topic, madam.
Yeah, thank
You
you.
so much. Thank you.
Yeah, thank you, madam.
Thank
We
you.
also like to thank our academic partner, Shield Pharma, for their support.
Yeah, good.